Subclinical hypothyroidism is basically when your FT4 is normal, TSH is 6 to 10. The cause is usually autoimmune, or rarely you can have a TSH receptor defect. The course is a high chance of remission, and this we'll discuss much more. Just to summarize the study, this was a study which looked into multiple trials. What it found was that this is a reversible condition. Most will improve by themselves. Even treatment doesn't have any benefit. So key message is less than 10, wait and watch. And people have tried to give a treatment with thyroxine. Again, no improvement was there in that regard. So now we will talk about the overall outcome of subclinical hypothyroidism and how do we go forward.
So with regards to subclinical hypothyroidism, the main issue with regards to it is the management. So when do we actually treat a case of subclinical thyroidism? That is the most common question. And also the other factors which we'll be discussing. Before that, we'll just discuss on the basic definition and its epidemiology. So with regards to definition, it is basically isolated hyperthyroidism or compensated hypothyroidism, which is biochemically classified as elevated TSH in the presence of normal free thyroxine levels. And its prevalence as compared to adults, it's low, but it is commonly encountered in a day-to-day practice. And because of the fact that its prevalence is more in adults, there are actually multiple guidelines and recommendations on treatment of subclinical hypothyroidism, whereas in children, there are few guidelines and recommendations are not very much clear. So we actually basically categorize subclinical hypothyroidism as into two, basically a mild and severe. So mild is basically between the upper limit cutoff for TSH and 10. And it is also referred to as grade 1 hypothyroidism. And it, in case if the TSH levels are more than 10 and FT4 is normal, then we classify it as a case of severe subclinical hypothyroidism. And in most cases, we generally require treatment for severe case of subclinical hypothyroidism. And with respect to the European guidelines of European pediatric endocrinology, they usually treat all cases of severe hypothyroidism, except in case of obesity. They generally recommend weight loss and only on follow-up. Even if the levels are above 10, they generally recommend weight loss and look for FT4 and TSH levels on follow-up, and they decide the treatment. And with regards to the course, as Sarah already mentioned, it in most cases, which is basically idiopathic, it is basically a benign and a self-limiting condition. And in most of the cases, it doesn't require treatment. And basically, the treatment is decided on the basis of three important things. So basically, when we have a patient with subclinical hypothyroidism, the one which we need to take into account whether there's a chance of progressing into a overt hypothyroidism or basically reversing back to euthyroid stage. So this is basically determined on the basis of the underlying condition which basically causes subclinical hypothyroidism. We'll discuss each other one by one. And the next important aspect is that what if he does not treat, so will it have an impact on growth or the neurocognitive function? As we all know that thyroid plays a very important role in case of brain development, also in case of growth. So in case if you have a child who is on prolonged subclinical hypothyroidism, will it have any impact on the growth, neurocognitive outcome or any cardiometabolic outcomes? And another thing is that we also have to identify the situation at which the patient is having subclinical hypothyroidism. This is very important because with respect to each situation, the treatment actually varies. So this we'll be discussing in detail. So as with regards to the Hashimoto thyroiditis, when you have a patient with Hashimoto thyroiditis, the rate of progression of subclinical hypothyroidism to overt hypothyroidism is very high, and it is almost seen in about 50% of the patients. And the rate of normalcy is very low. It is only less than 10%. Whereas in case of idiopathic subclinical hypothyroidism, this is exactly opposite. We have a case of reversal to euthyroid stage is almost 40%, whereas the progressive to worsen to overt hypothyroidism usually less than 10%. And with regards to the factors that basically causes deterioration of subclinical to overt hypothyroidism includes the presence of goiter, higher TSH and TPO antibodies at the time of diagnosis, or whenever there's an increase in the TPO antibodies and also TSH, and in presence of any other autoimmune disease, as already discussed by Sir, where in case of celiac, the prevalence of autoimmune hypothyroidism is around 10 to 20%, and in case of type 1 diabetes, it is even more. So whenever we have a patient of subclinical hypothyroidism, we need to look for two important things. Basically, one is the clinical examination, looking for the presence of goiter, which supports to a case of Hashimoto thyroiditis. And the next thing is that we need to get an anti-TPO done, which will help in the management of subclinical hypothyroidism. And I'll be discussing on that later. And with regards to the genetic syndrome, as already mentioned, these genetic syndromes are most commonly be associated with hypothyroidism and also subclinical hypothyroidism. And with regards to Turner syndrome, the prevalence is 40%. And in case if the patient is having subclinical hypothyroidism, then the chance of progressing to overt hypothyroidism is around 60%. So we need to treat a patient of Turner syndrome with subclinical hypothyroidism immediately on thyroxine. And apart from that, we also need to consider hypothyroidism whenever a Turner syndrome child shows a deterioration in academic performance. The first thing we have to look in for thyroid and also look for the hearing. And with regards to Down syndrome, my dear colleague Manoj will explain everything in detail. And this is also one of the case of Williams syndrome. The patient did not have hypercalcemia, but had subclinical hypothyroidism and was started on thyroxine. And with regard
PHP every time maybe.
And PHP is also one of the very common condition where TSH elevated, which is much more elevated even during the infancy, whereas the other endocrine complications usually come at an later age. So in case if you are able to identify PHP, we can anticipate for the other complications of hypocalcemia and also other hormone resistance. And in case of obesity, which is very common, this is the most common cause of subclinical hypothyroidism we generally see in our routine practice. And the question basically arises whether we have to treat it or not. The prevalence is around 7 to 23%. And the basic pathophysiology, which is already discussed by Sir, it is basically because of the adaptive mechanism, and leptin causes activation of the hypothalamo-pituitary thyroid axis. And in case with regards to the management is considered only in case if there is anti-TPO positive. Otherwise, we can actually encourage weight loss and repeat the values and see the values are coming down or not. And it has also been found that giving thyroxine does not help in any form of weight loss. And with regards to drugs, the Sarah has already discussed, it includes the anti-epileptic drugs, antiretroviral, amiodarone, and also interferon alpha. And with regards to nutrition, which is very rare these days, it could be because of iron deficiency, and in case it's very rare of iron excess. And the most important situation where we should not miss a case of hypothyroidism, subclinical hypothyroidism, is radiation exposure, and where we need to have a very small cutoff for treating subclinical hypothyroidism. This is one of the very important conditions and very important history we need to ask for a patient with subclinical hypothyroidism. And the next important condition after the radiation exposure is the neonates, because this is the crucial period for brain development. So we need to intervene early, and we also need to identify the cause, which is very, very important. And as we already discussed in the previous class, when the TSH are sky level high, we usually, there's no point of doing much of thyroid scan, because it is not going to alter much in our treatment. But whenever we have a subclinical hypothyroidism, as already mentioned in the previous classes, with TSH between 6 to 20, that is where the investigation play an important role, and it helps in deciding the treatment. So with regards to the causes, as in neonates period, it could be because of the mutation, genetic mutation in the form of TSH receptor or DOX2. And as already mentioned by Sir, in case of TSH receptor mutation, it is one of the very common condition of persistent subclinical hypothyroidism, where there's the hypopituitary thyroid axis is slightly changed, and it is considered to be outlier of the normal value of 5.5. And in most of the cases, what we basically find that whenever there's a patient with or a neonate with subclinical hypothyroidism, when we actually get a scan done, we used to find so many abnormalities in the form of hemiagenesis, thyroid hypoplasia. And it is also important to look for other most important causes in the form of prematurity, and also maternal drug intake in the form of anti-thyroid drugs and also amiodarone. And we need to have a very detailed history in the form of any positive family history, and also look for any drug intake in the mother. And in this case, it is very important, as I already mentioned, that we need to go in for investigation and we need to treat. This was the study which basically was done in the 2008, when they actually evaluated the patients of neonatal subclinical hypothyroidism. Out of the 44 patients, nearly 30 patients had some kind of defects, which could be in the form of morphology, in the form of hypoplasia, hemiagenesis, and or genetic forms, which could be in the form of TSR receptor mutation, which would later present with overt hypothyroidism, and it can also result in mental retardation. This is one of the very important conditions. There are two important conditions which we require emergent treatment with regards to subclinical hypothyroidism. Is basically the exposure to any form of neck radiation, and the second most important thing is the neonatal period, where the time is more crucial and evaluation is very important. And with regards to transient, it could be either physiological. Physiological could be because of any form of sleep deprivation, which basically causes a slight elevation in the TSH level, and also during the peri-ovulatory period where there is a TSH surge. And apart from one of the common conditions, which is already we discussed in the previous classes, is the macro TSH, which is usually as a problem with immunoassay, where there is a high molecular weight complex of TSH, which are present biologically inactive and which are present in the circulation and may cause false positive.
These are anti-TSH antibodies.
Yes,
which will go on to that. So they will look bigger than as compared to their normal size. So machine will say the results are very just like prolactin.
And this is more commonly seen when there is an history of recent transfusion or immunization or any form of monoclonal antibody. And in this case, it is wiser to repeat the testing in the next 4 to 12 weeks and repeat it via using either doing a PEG ligation or using a gel filtration chromatography. So the most important thing from identifying the cause, next the thing is that whether prolonged long-standing hypothyroidism will have any effect on the growth, neurocognitive outcome, and also cardiometabolic issue. So with regards to the growth, there are many studies which have been done, which have compared the patient with prolonged subclinical hypothyroidism and controls of euthyroid patients. They found that the linear growth, bone maturation, and the IGF levels were found to be similar in both the groups. And with regards to neurocognitive income, there are actually results are one side they say that there is some form of verbal decline or some form of IQ decline in patients with prolonged subclinical hypothyroidism. But in the recent study, which was published in the year 2020, which included a lot of patients with subclinical hypothyroidism, and were followed up for a period of 2 years, which clearly says that the global IQ, verbal IQ, and the performance IQ were similar in both the groups. And with regards to the cardiometabolic outcome, this is the one thing which almost all the studies have shown to have an adverse outcome on the lipid profile, which basically shows subtle pro-atherogenic abnormality in the form of high cholesterol, high triglyceride, high non-HDL level cholesterol, and non-HDL low levels of HDL cholesterol. And it also found to have an increase in higher levels of homocysteine and dimethyl arginine levels, which is basically a competitive inhibitor of nitric oxide synthase, which basically increase the risk of thromboembolic phenomena. And these studies also support the fact that on supplementation of thyroxine, they have showed that there has been a decline in the levels of homocysteine and ADMA. However, despite all studies showing similar results, but the thing is that they had a very small population, and also they were cross-sectional studies, and they were not, and some of the studies did not have a long follow-up. So these studies are actually has to be these reports has to be supported only in case if they have a very large population, and also has to be followed for many years. And with regards to the management,
now, okay, so this is important that you can have metabolic impact, and this is also being shown in our study that you can have higher prevalence of NAFLD. The most important predictor of NAFLD was not body fat, was not level of obesity, not BMI, but TSH. So high TSH is a risk factor for NAFLD. So this all are similar. So whether that represents you have a severe disease, you have a high TSH, and that's why you have NAFLD, or thyroid is causing them is a question. But this is associated.
So with regards to management, whenever we have a patient of subclinical hypothyroidism, we need to look for history and examination. In case if there is a definite history and definite clinical examination showing goiter, so we can directly go in for the TPO antibodies. And in case if there is no evident clear-cut history or examination, then we need to repeat it after 4 to 12 weeks. And in case of when we repeat it, if it is normal, then it is basically a transient phenomena, which could be related to ovulation or sleep, decreased sleep. And in case if you repeat it, if it is showing overt hypothyroidism characterized by low FT4 levels and high TSH, then we need to immediately start treatment and also do a particular investigation to identify the particular cause. And in case if the repeat investigation also shows feature of subclinical hypothyroidism, next most important investigation is to do a TPO antibodies. In case the TPO antibodies are positive, then still if the levels are between 4.5 to 10, we can actually wait, and we need to do a periodic follow-up of every 6 monthly to see the progression, because as Saul already mentioned, TPO positivity causes hypothyroidism only in 10% of patients over a period of 5 years. So in patients with TPO positivity and if there is subclinical hypothyroidism, in the absence of goiter and also symptoms, we can actually wait right before starting on treatment. But if the TSH levels are very high of more than 10, and in case if there are presence of goiter, then we need to start immediately. As I already mentioned, presence of goiter and presence of high levels of TPO are one of the very important risk factors for progression of subclinical hypothyroidism to overt hypothyroidism.
What is significant TPO quality?
So more than 3 times.
This is important because often when we say level is up to 30, 40, 45 doesn't make much problem. Usually if you have a disorder, it will be like hundreds or thousands. So if it is very high, the chance of it having a disease, reflecting a disease will be more likely. Otherwise, if it's 40, 45, don't worry.
So the next most important cause is the obesity. In this case, whatever the levels, unless there's no decline in the FT4, they generally tend to encourage weight loss and repeat it on follow-up. And in case of irradiation, this has to be individualized on the basis of what was how much amount of radiation, where was it given, and for what reason has to be given. So we need to basically individualize the treatment based on the type of radiation. And with regards to drugs, basically we need to periodically monitor every 6 months to look for FT4 and TSH. In case the TSH levels are more than 10, then we need to start on treatment. And this is the most important condition where the neonatal, where we need to immediately evaluate and look for the cause. If there is any obvious cause which is known to cause overt hypothyroidism, then we need to treat immediately in cases of subclinical hypothyroidism. And in case if there is no presence of any obvious cause, then we need to wait, follow up every 6 monthly, and in case whenever there is an increase in TSH level, then we need to go in for treatment.
So goiter, irradiation, strong family history, and if you can add maybe in this, if there is any mood disturbances in older individuals, of course, pregnancy planning will be one factor, and these will be the indications we would treat. Otherwise, wait and watch.
So actually, we had a case where we with respect to this today's class, we just had this patient who came just 2 hours before, 8-year-old boy who actually presented 2 years before for the first time with the presence of swelling in the neck. And when we got the investigation done, we found that the TSH was normal and FT4 also was normal. And we also got a TPO antibodies done, which was negative. So we have a patient with normal euthyroid function with goiter. So we reassured him. And after 2 years, the father found that there was an increase in size of the swelling. So we again repeated the function, and we found that the TSH increased from 3.75 to 6.5, which basically touches the figure of subclinical hypothyroidism. So when we have a patient with subclinical hypothyroidism and in the presence of goiter, so we need to start treatment because the patient can progress to overt hypothyroidism. So
3 things which are there in this case. One, the swelling
increases.
Second was that he is not pubertal and yet his TSH increased significantly. And as we discussed, the intra-individual variation of TSH is much lower than inter-individual. So if you know somebody's baseline and it has increased, it will make more sense. Suppose it was 5.5 and it became 6, doesn't matter. If it is 3 or something and then becomes 6.5, it may be more significant for this child. Increase in size, TSH being on the higher side, then we can consider treatment. But again, mostly treatment may be stopped later on if things are normal.
So the patient was started on thyroxine.
What dose will you start if it is subclinical?
So we can start at a lower dose.
So generally 50%
of
of the dose. So